This video will give an overview of an assessment framework in a competency-based environment and an introduction to a portfolio. These are some common assessment formats that are currently used in a residency program. Written exams, the ITER, the OSCE, and more recently the mini CEX that will be the basis of competency-based medical education, but I'll explain that in a bit. The oldest form of assessment is the written exam. The written exam is a useful format for assessing knowledge and can do it in quite an efficient way, especially in the multiple choice questions. And not only can it get at basic science knowledge, it can get at applied knowledge and higher level thinking. However, it is limited by the fact that it's an assessment of knowledge, not of actual skills. That's what led to evaluations in the workplace, such as the in-training evaluation report, or ITER. Now, there are problems with ITERs. First of all, we've had a problem locally, and this has been nationally and around the world, where ITERs can get to be very long. And with that, you get rater exhaustion, and then you end up having this phenomenon where people circle all threes, all fours, all fives, without even really reading what the scales mean. Part of the problem is that an ITER is done after 1, 2, 4 weeks or even longer. Hence, we need to cram so much into it. Now, although we've done a lot of work to reduce our ITERs, and our current ones are around 8 to 10 rating scales, there's still a problem that the ITER is done at the end of a time together. And what can happen is that one good or bad encounter can really bias that time with the resident. And so it's harder to get an objective observation with all the blur over the last week or two. That's not to say ITERs are going away, because there is valuable data that comes from the ITER that is dependent on that longitudinal relationship, even if it's just a week or two. But what we need are multiple short samples in order to get a better sense of what the resident can do. That was the original idea behind the OSCE, the Objective Structured Clinical Examination, was to have multiple different stations biopsying different skill sets so you can paint a picture of what the resident could do. Now, one of the good things about the OSCE was when it was introduced was the standardization compared to just having an oral exam and a random patient that was brought in. However, it's been well recognized that standardization is at odds with authenticity of the messiness of real clinical medicine. So what we need is these multiple snapshots, biopsies in the workplace. And that was the idea behind the mini CEX, a mini clinical evaluation exercise where the resident could be watched for 10, 15, 20 minutes, do a history and physical, and kind of synthesize the case. And there's good evidence that the mini CEX has validity, and actually in the GIM program at UBC, they showed they could correlate scores on the mini CEX with the Royal College exams. Now that's all great, but an observation of 15 to 20 minutes, that's still hard to do in our busy workplace environment. But having these short biopsies is the basis of competency-based medical education. And essentially, the mini CEX in a shorter form is what an EPA observation is about. Just a short observation of a goals of care discussion, or putting in a central line, or how you manage a specific case and explaining it to the family. These can be done in 5 minutes. And we have developed for this last year a way to do this with Google Docs on a mobile device. And we're going to be moving towards a new portfolio with some collaboration of the MD program here at the U of A. The one thing that I want people to remember is we're no longer calling it the mini CEX, we're calling it EPA observations, although the process is essentially exactly the same. Now, this is all great to have these assessments, but especially currently they're housed in 3 or 4 different platforms. And that's part of the idea behind a portfolio. A portfolio is a one-stop shop for the assessment, but it's not just a collection of works. It also has a reflective component for the learner to provide a commentary. And a portfolio can serve both as a vehicle to promote reflective learning and evidence of that reflection and learning. This is one thing that's getting a bit lost as people talk about ePortfolio and all the assessment platforms, is we need to still have an ability for the resident to reflect and document that reflection. Now, given reflection is an important part of a portfolio, one thing we realized in our program that was missing was self-assessment. And so for this last year, 2016 to 2017, we've asked the residents to document a self-assessment in their portfolio once after each rotation to get a sense of how they are doing. And this is an important part of competency-based medical education, that the resident is demonstrating that they are reflecting on how they are doing, and this can allow the academic advisors to also help them out. Now, all of these go into the portfolio. And the portfolio is used by many people. It's used by the resident to keep track of how they're doing, how many EPA observations have I captured, how am I doing in the various domains. It's used by the academic advisors to coach the resident, the program directors to get a high-level view. But also it's used by the competence committee we described in the last video, who looks at the portfolio to get a sense of, has the resident got enough data to demonstrate competence in each of the EPAs? Now, one question that comes up from residents is, well, how many observations do I need? So is it, if I get these 6 observations, I'm done? And both unfortunately and fortunately, it's not as simple as that. Although the residents will just want a number, the idea behind a competence committee is that they can look at the subjectivity of narratives, of the comments written. Sometimes 3 observed goals of care discussions, although a rater might say, I didn't really have to change anything, you get the sense from the comments the resident's not quite there. As opposed to another one where they have their 3 observed, but it's clearly obvious they've definitely mastered this. And so the numbers we're going to be telling the residents are the minimum required, but it does not automatically make it sufficient if there's ongoing comments to suggest there's some work that needs to be done. So there may be circumstances, in a minority of cases, a resident has the minimum number, but based on comments or themes in other assessments, the competence committee might say, we're not there yet. Maybe let's get a few more observations and work on X, Y, or Z. So that is an overview of the assessment framework and an introduction to portfolios.